Hello, my name is Leat Perez, and I'm going to be a senior at Beaumont High School this year. And I was fortunate enough to have the opportunity to take part in the science internship program at the emergency department with Dr. Elaine Thalner. The project I conducted was emergency department education of hypertension patients. Is there an opportunity to impact public health? The United States emergency departments have more than 115 million patient visits per year, and unfortunately, many of these patients lack access to primary care physicians. Therefore, a huge burden is placed on emergency physicians to treat the patient's acute problems, but also practice preventative medicine. Blood pressure, the force that blood exerts on the walls of blood vessels, consists of two different measurements. The pressure when the heart is beating is known as systolic pressure, while the pressure when the heart is resting is known as diastolic pressure. In most cases, there is no known specific cause of isolated systolic hypertension. However, factors that can increase a person's risk of developing this condition include age, obesity, smoking, lack of regular exercise, excessive salt, caffeine, or alcohol intake, and a history of diabetes. Studies have shown that Caucasian males and African Americans of both genders have increased risks of being diagnosed with hypertension. Isolated systolic hypertension, when combined with other risk factors such as poor diet and lack of exercise, can lead to serious health problems like stroke, heart attack, congestive heart failure, chronic kidney disease, blindness, arteriosclerosis, and dementia. Because of the future ramifications of untreated hypertension, sometimes an overdiagnosis of hypertension can occur. For example, the theory known as white coat high blood pressure can be misleading because blood pressure elevation may only be temporary. This elevation may be caused by a patient's anxiety related to stress and fear that health problems may exist. Accordingly, 1 out of 4 patients diagnosed with mild hypertension have normal readings outside the emergency department or their physician's office. Patients diagnosed with hypertension have different forms of it. Essential hypertension is far more common condition and accounts for 95% of hypertension diagnoses. Essential hypertension affects more than 72 million Americans, and yet its basic causes are unknown. Secondary hypertension, however, suggests that a patient's hypertension is second to a specific disorder of a particular organ or blood vessel, such as the kidneys, adrenal glands, or aortic artery. Both forms of hypertension can lead to life-threatening conditions if gone untreated. In spite of the prevalence of hypertension and prehypertension, the first step in treating a patient is educating them. The next step would then be to prescribe the patients with antihypertensive medication. Dr. Greg Henry, the past president of the American College of Emergency Physicians, when asked where healthcare will be in 2020, said, quote, "If you observe where medicine has been going, it is clear that hospitals will basically become emergency departments with holding units, intensive care units, surgical suites, and pretty much nothing else," end quote. While emergency physicians have the task of treating the patient, considering cost efficiency, and perhaps even the environment, because the lack of primary care physicians and the evolution of the healthcare system, in the future, ED physicians will have to consider the patient's underlying conditions as well as their acute emergencies. High blood pressure is called the silent killer because patients are often asymptomatic for years until their critical organs are damaged. Therefore, we took the initiative to proactively address this problem. Because a lot goes into emergency medicine and how ERs function, my project consisted of the following 4 hypotheses. 1. Emergency medicine does not routinely provide hypertension discharge instructions when patients are noted to have asymptomatic hypertension. 2. Abnormally high initial systolic blood pressure is repeated during the emergency department encounter. 3. Patients without a known history of hypertension are more likely to receive discharge instructions that address hypertension. 4. Patients with a high acuity level are more likely to receive discharge instruction addressing hypertension. To examine this, the EPIC records of all ED patients during the month of June 2011 were retrospectively analyzed. Charts of patients with initially elevated blood pressure were closely examined to determine whether or not their BP was retaken during their ED visit, whether or not they had a prior history of hypertension, and whether or not they were provided with education, specifically discharge instruction, addressing the future repercussions of elevated blood pressure and the need for a follow-up. All patients with systolic blood pressure greater than 165 millimeters of mercury were then separated into subgroups. The groups consisted of patients who either had a repeated BP or did not have a repeated BP. If the BP was retaken, if it remained elevated, or if it was decreased, and then also the patient's acuity levels were noted. In the emergency room, the triage nurses assign patients with an acuity level, which then indicates to the physician the urgency to treat certain patients before others. Acuity levels range from 1 to 5, where the lower your acuity number is, the greater of a priority you are. When assessing the association between these categorical variables and analyzing the data set, Pearson's chi-square test and Fisher's exact test were used. According to the information in the charts, patients were separated into their corresponding profiles. Out of the 365 patients in the month of June 2011 who came to the ED and were recorded with high BP measurements, 78 patients got their blood pressure retaken and it remained high. 32 patients had their BP retaken and it was lowered. Interestingly enough, 88 patients came in with initially normal readings, but when their BPs were retaken, they presented higher measurements. That group is probably the portion of the population which presents white coat high blood pressure. And lastly, 167 patients who initially had elevated blood pressure measurements lacked documentation of a repeated blood pressure measurement. This here is a chi-square assessing the correlation between the patient's classified profiles and whether or not he or she received discharge information addressing hypertension. As expected in this cohort, there is sufficient evidence to support the claim that the patient's profile is associated with whether or not he or she receives discharge instructions. Because the p-value, which was calculated using a statistical software program called JUMP, is below 0.05, the dataset is considered statistically significant. In fact, the p-value in this cohort was 0.0001, which enforces the strength of the association of these two categorical variables. Furthermore, we have rejected the null hypothesis. While this correlation remains logical, the portion of patients who did not receive discharge information and who were in the profile of high was staggering. 76% of patients with BPs that remained high were not informed about hypertension. Clinically, the goal is to inform people at risk of isolated systolic hypertension at a rate of 100% by providing them with education so that they can arrange a follow-up with a primary care physician. When isolating the patients in the profile of high, there was insufficient evidence to support the claim that a patient's medical history is associated with whether or not he or she receives discharge instructions. Because the p-value of this analysis is 0.2496, the data is not statistically significant. Furthermore, in this cohort, the evidence has failed to reject the null hypothesis. This chi-square assesses the correlation between a patient's acuity level and whether or not they receive discharge instructions. In this cohort, the patient's acuity level was associated with whether or not he or she received discharge information because the p-value was 0.0051, although it is most probable that this correlation was subconscious. This pie chart represents the number of patients who received discharge instructions versus those who did not receive any information on hypertension. Out of the total population of 365 patients, only 11% of patients received education. At this rate, 220 to 300 patients per year at the Cleveland Clinic are not being informed about hypertension. On a national scale, these numbers can be even more startling. The previously undiagnosed group provides the greatest opportunity for positive long-term public health impact by ensuring follow-up care, yet most did not receive hypertension discharge instructions. Emergency medicine is structured to handle acute emergency situations and does not historically view itself as a primary care field. In a changing healthcare environment with less access to primary care, emergency medicine may need to expand its traditional acute role to manage more chronic diseases such as hypertension. Many patients whose repeat BP was not documented may have had a subsequent normal blood pressure. The automatic blood pressure machine used in the emergency department is capable of taking blood pressures at regular intervals, but the data does not download into Epic medical records. Documentation of BP requires a manual entry, generally by nursing, which is a challenge given nursing workflow. In December 2010, the emergency department went to Epic programming, so there was a change in workflow as well. It is also possible that some patients have continued hypertension and it is simply not noted. In order to ensure that these patients receive hypertension-specific discharge instructions, an IT solution would be ideal. All blood pressures taken with the ED machines would download into Epic, where it would be visible to emergency department providers. Epic could identify patients with no prior history of hypertension and auto-populate appropriate discharge instructions for the patient. This would assist the ED staff in ensuring appropriate education when they were focusing on the patients presenting complaints. I would like to thank the Office of Civic Education Initiatives, specifically Nedra Starling and Rosalind Strickland, my mentor, Dr. Elaine Thalner, as well as the entire emergency department, and Amy Nowacki for helping me with my statistics. Thank you.